Hi, how are you?
Good. How are you, Lily?
Good. I'm going to stop sharing my screen for a second. I just want you to try to share your slides now.
Okay.
While we wait a couple minutes for everybody to join, and then I'll put my little reminder slide back up after
All
that.
righty. Get this right. How's that?
That looks good to me.
Okay.
Perfect. Okay, great. We won't be able to see the participants. They can't turn their videos on or go off mute, but they can put things in the chat. They can put things in the Q&A, so we'll help facilitate that as we go.
Oh, wow. Okay. That's
We'll
good to know.
probably leave about like 10 or so minutes at the end for questions. So we'll stop at that point and take any questions that people have, so we won't take them throughout the session. Um, so we'll monitor everything. We'll also put any like references or resources that you mentioned in your slides in the chat as we go too, so attendees can have that as well. Um, yeah.
Okay.
Oh, you know what? I'm seeing like a block.
Oh, yeah. Thanks.
Perfect. Look
Should
great.
I try just this little video?
It's playing. I
Mental health
can't
is the
hear
part of
any
health
sound.
that allows
Oh,
us
now I
to
can. Mm-hmm.
Okay.
That worked.
I can't hear music.
I think we can hear it.
Mental health is the part of health that allows us to have
Yep.
feelings and experience them, organize our reactions to I think that's the only video.
Okay, great. Wonderful. We will give people a
strong
couple of
feelings,
minutes
build
to hop on.
relationships.
I'll start off by just kind of introducing BHIP a little bit, and then I'll introduce you, and then I'll hand it off to you.
And what time should we like what time should I stop by?
I'm thinking like 12:50 would be great.
12:50. Okay. Oh yeah, that's when I share. And then I think, have one question. Mental health is the part. Um, okay. How many people do you think will come? So it's not interactive at all. It's really just like a
Yeah,
talk.
that's okay.
Okay.
We had 105 people register.
Oh
So
wow.
yeah, so
Okay.
we'll see. Um, it always just kind of depends sometimes, especially with primary care providers. They intend to come and then their schedules get busy
Yeah.
and they run into their lunch hour. Um,
I do that with trainings too. I say
yeah,
yes and then
yeah. So we know that happens, but we're hoping for a good amount of people.
okay. Better.
Welcome to those of you that are joining us. We'll get started in just a few minutes. In the meantime, please feel free to introduce yourself in the chat. Just make sure you select everyone when you're using that chat function. We also just have a slide up with a few things to remember, so your cameras and microphones are disabled. So use that chat function if you have any questions, comments, or if you need any support. You can also use the Q&A function for any questions. We're going to leave about 10 minutes at the end for questions. If you're participating today to receive CME or CU credit, you'll need to attend for 45 minutes or more to receive your certificate. And all participants who'd like to receive credit will need to complete the evaluation survey after the session. And CME and CU certificates will be sent out by May 7th, along with a link to the recording of today's session, the slides, and a list of related resources. And those materials will also be uploaded on our website early next week as well. So again, we'll get started in a couple minutes. And thanks for joining.
And Lily and Grace, do you know the different roles that people have? Are there, or is that something you ask when people come on?
We do ask that in the registration, so
Oh,
we will
okay.
be able to see that, but we kind of get a range. We get primary care providers, so physicians, so MDs, DOs. We also get MPs, PAs, also licensed counselors and licensed social workers as well, and some that are working in the primary care setting, some in the emergency medicine setting, and also some in school-based health centers as well,
Oh, cool. Great, great, great.
and some maybe behavioral health providers that are in mental health settings as well. So kind of a big range.
Yeah, thank you.
Mhm.
And you like to have the questions at the end?
Yeah, we'll
Uh-huh.
wait. We'll take note of all the questions that are asked throughout, and then we'll go over them at the end.
Okay. And can I ask a question and people put it in the chat or no?
Yeah,
Okay.
absolutely. Yeah.
Hmm.
Okay. It's 12 o'clock, so we're going to get started. Welcome, everyone, and thank you so much for joining us today. My name's Elise Tabisky, and I'm the Outreach and Training Coordinator for BHIPP. I'll be introducing our presenter for today and facilitating the Q&A at the end of the session. For those of you that are unfamiliar with BHIPP, I'd like to provide some information about our program. So Maryland Behavioral Health Integration and Pediatric Primary Care, or BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care providers and emergency medicine professionals in addressing and managing the mental health concerns of their patients. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, telemental health services, and training and educational opportunities. The BHIP Warm Line is staffed by a team of child mental health specialists, and it's available Monday through Friday from 9 a.m. to 5 p.m. And we will put our phone number and website in the chat for you. It is my pleasure to introduce today's BHIP webinar, Infant Mental Health in Primary Care Settings, presented by Kay Connors. Kay Connors is a licensed clinical social worker at the University of Maryland School of Medicine in the Department of Psychiatry. Ms. Connors is the project director of the Baltimore Linking Action to Unmet Needs in Children's Health and the executive director of the Taghi Modaresi Center of Infant Study and the Center of Excellence for Infant and Early Child Mental Health. Ms. Connors has over 40 years of experience as a clinical social worker working with children, families, and communities impacted by trauma, and has provided evidence-based mental health treatment to children and families in a variety of settings. Ms. Connors directs clinical and training programs, including the University of Maryland School of Medicine's Healthy SEP sites, supervises staff, and is also a co-investigator in research grants. Ms. Connor leads innovative learning projects, including Breakthrough Series collaboratives, and she is a national child parent psychotherapy trainer, a master ACE interface trainer, and the director of Maryland's Infant and Early Childhood Mental Health Certificate Program and Fussy Baby Maryland, and is a co-creator of this curriculum developed with the University of Nebraska Medical Center, Monroe Mayer Institute through the Region 7 Mid-America Mental Health Technology Transfer Center Network, and it's under a cooperative agreement from Substance Abuse and Mental Health Services Administration, or SAMHSA. We are very grateful to have you here with us today, Ms. Connors, so thank you so much for sharing your expertise with us during this session, and I will hand it over to you.
Thank you, Lily and Grace, and thank you everyone for joining this morning or this afternoon. It has been a wonderful project to be a part of, and with my collaborators, Dr. Sarah Edwards and Antonia Gerard. And if you want to stay connected to the series, I'm just introducing the series today with Module 1, but there are other modules and Lily already kind of helped with that. So thank you, Lily. Our acknowledgments. This is a curriculum that covers most of these competencies that were developed and highlighted for primary care providers. Not only the pediatrician or direct medical provider in the practice, but also in hopes to provide resources for nurses, counselors, social workers, other people in the program that play the integrated behavioral health role in primary care. So with that said, today is the overview session, and we'll be defining what we mean by infant and early childhood mental health, understanding prevalence rates and outcomes for untreated early childhood mental health disorders. And that's a little bit of a highlight. I'll be repeating myself there a lot to make the case that early detection is really critical to children's health. And describe medical and mental health providers' role within the pediatric or primary care setting, and identify some strategies to integrate mental health into busy pediatric workflows. So some of the competencies that we're touching on today are child development and the recognition of evidence-informed practices for screening and monitoring development, and how to do that within a family-centered approach. So let's start with the definition. Definitions are really important to the team, but also as we talk through things today, are important to our partnership and engagement with families. And you can see on the left side of the screen are a list of things that might be often referenced as social determinants of health, or childhood traumas, or adverse childhood experiences. And why this is so critical to the discussion of early childhood mental health is actually a study that just came out from the University of San Francisco this last month in March, showed through their work and also a meta-analysis of 18 studies that 24% of children under the age of 6 exposed to trauma um, develop traumatic stress disorders compared to 16% of older kids. So we know that during these critical windows of opportunity and development, we also know that kids are at greater risk to these family and environmental factors. And on the right-hand side of the screen, you see the definitions of the things that you all know so well. In some cases, mental health is referred to as behavioral health. Certainly, neurodevelopmental issues are often and can be identified in these early years. Psychiatric conditions like anxiety and traumatic stress, like I just discussed, as well as psychological concerns, including learning and cognitive developmental concerns. Also, somatic concerns like eating disorders are quite common in infancy and early childhood. And then social emotional development is both an opportunity in these early years to really enhance that developmental domain, and it's also foundational to children's overall development and the impact of toxins, including substance exposures on young children. So it's really a very wide umbrella that the work kind of sits under. I'm going to show just a 1-minute video of Mary Margaret Gleason, who's a triple boarded physician in pediatrics, general psychiatry, and child and adolescent psychiatry, and really been a champion in our country for integrated behavioral health, particularly focused on these early years.
Mental health is the part of health that allows us to have feelings and experience them, organize our reactions as strong feelings, build relationships. It's how children can function. When children have mental health problems, it gets in the way of all of those activities, functioning in families, learning in school, being able to build peer relationships and participate in extracurricular activities. And it causes suffering. Most of these mental health problems don't get better on their own. And so what we need to do is to offer children and families tools, skills, therapy, and sometimes medication to address their medical conditions, their mental health problems, so that they can function and to the best of their abilities, learn, make friends, and build relationships.
And that's really the opportunity that we're talking about here and through BHIPP and through this series. And an operational definition of, or at least my favorite operational definition of infant and early childhood mental health is that it's our job, providers, parents, community at large, really, to help children grow well and learn well. And I think that is a way that we can talk about a often stigmatizing topic with parents and define it in a way that is very growth oriented. So what do we mean by that? We mean that we help children develop coping strategies and ways to manage emotions, including experiencing big emotions and difficult emotions, being able to tolerate a range of emotions without a lasting emotional collapse. Temper tantrums are normal, but if they're lasting hours long, get in the way of you going to school, that's when we want to get some support. Relationships. Children's development happens within the context of loving, nurturing, competent relationships. And so being able to provide resources for families so that they're able to support their children's social emotional development and help their children learn to be in relationships and develop close and trusting relationships. And then the third aspect is child development really is there to kind of help children be successful in the environments in which they live. And that really depends on the cultural values, the activities, the things that families and the community think are important for kids and the opportunities they set up for children. Often in America, what we hear most from parents is school readiness. We want to help our kids be successful in school. So that's kind of a way to think about kind of how culture shapes child development in these years and what we can do to help set kids up for success. So I was wondering if you could, and Lily could help me, is just pick a percentage that you think might represent the prevalence of early childhood mental health concerns. So what percentage of all children do you think have indicated mental health concerns in these early years?
Somebody said 75%. Another said 50%.
Okay.
Another
Did you say
50.
okay?
68, 25, 55, 70, 20.
Wow. Well, the good news is about 17%, which is just slightly below what older children's prevalence rate of a mental health condition is. But I think the large numbers that people said it really kind of points to the importance of focusing on mental health, that all children need that focus, but about 17% actually have meet the criteria for diagnosable disorders in this age group. And so pediatricians and primary care providers really are positioned well to recognize these developmental differences um, and be able to provide care coordination to support families and promote development. So let's break it down a little bit more to the research, what the research shows us about how to understand how infants and toddlers display mental health concerns. So about 7% of infants and toddlers have emotional and motor regulation difficulties. Another 25% have feeding problems. And I think that's pediatricians are often, spend a lot of time talking about feeding and sleeping concerns. One of the most serious conditions for this age group is attachment disorders. And about 1% of children have that. And that is largely found in children that have experienced multiple separations, might be in foster care or congruent care. About 10 to 20% have anxiety disorders, including the traumatic stress disorders that we were referencing, and about 2% depression, often related to grief. Another important group of kids to really pay attention to are kids that do have developmental delays and or are diagnosed with a range of developmental disabilities. About 1 in 6 of those children also have a co-occurring behavioral health need or condition or diagnosable disorder. And so being able to really hold both and focus on those the needs of both are really important. And unfortunately, in our early intervention area, those mental health condition treatment concerns are often referred out. So how to integrate that either into the primary care or into early intervention or to make relationships with community providers that have this training. So what does the course of illness look like in this age group? Not surprisingly, disruptive behavior disorders, things like ADHD or oppositional defiant disorders are the most frequently diagnosed disorders for children in this age range. And this is because parents are more likely to report worries about these disruptive behaviors, and because they get in the way of family life and their overall concerns about relationships or how their performance in school or childcare. These symptoms include significant and frequent tantrums, aggressive behavior, noncompliance, aka he is not, she is not listening to me, and often are evident as early as 1 to 2 to 3 years old. So it's really important. The research does show that parents are good at detecting these developmental variances. So when parents are bringing this up, it's important to really center it as a primary concern. We also know that children, kind of getting back to our first slide, that children that are living in families that are experiencing high amounts of stress, disruptions, changes, or living with parents that have untreated mental health or substance use concerns, or families that are living in poverty or have lack of resources, are more prone to these uh, presentations, developmental and behavioral presentations. So we, unfortunately, children, this is true kind of across the age range, but quite even more so in these early years. Young children with identified behavior, only less than 25% receive any kind of behavioral treatment, including assessment. So there is a need, and the need is challenging to meet. So how can we, think about enhancing the primary care relationship setting or resources that go into supporting primary care to address these concerns? This is some research from the National Academy of Science and Engineering and Medicine, a report that they wrote in 2019. Though the first one is a little bit out of date in our current time, but for many, many years and decades, there was a reduction of serious infection and disease. So, that's a big win for pediatric healthcare. And there's been increases in treatment and recovery rates for acute illnesses. But at the same time, so as we made that kind of progress, at the same time, there's an increase in metabolic and mental health conditions, and particularly for the children before the age of 5. So what are the opportunities that we can tap into together? The first 1,000 days is a really remarkable time period where both a pregnant woman and her partner can have a lot of access to physicians, including their OBGYN. They're making relationships with primary care physicians and maybe other supports, doulas and lactation specialists and other people to prepare for the transition into parenthood. And then the infant and toddler has many touch points with the primary care team and physician during those first 2 years of life. So that is a unique opportunity within this important 1,000 days of physical and importantly brain development. So the primary care perspective really kind of holds the expertise around biology, and also, kind of what is being disruptive in a child's health or developmental trajectory, and supporting development as an important role in primary care. And that is all kind of related to the context or the ecology of the community, of the family, or even the primary care setting itself, what kind of resources the primary care setting has access to. So the World Health Organization, declared that there can be no health without mental health. So really incorporating kind of within this Venn diagram, the role of mental health, the supports and resources and relationships needed to enhance children's mental health, really starting really in the pregnancy period. So about 25% of the 150 million child visits per year for primary health care do focus on these psychological or mental health problems. So pediatricians, as you all know, are really the first touch point that parents and people that parents turn to. And many visits are just focused on mental health concerns. So how can we bring resources to you all that help you with early detection so that those later appointments that are about psychological problems that turn into crises can be reduced or, addressed effectively? So what preventive measures, including community partnerships and resource maps to know who to turn to, and what kind of integrated care strategies are possible for your practice and your teams and your community. And then tailoring interventions that can be delivered within the primary care setting. One that we're very focused on here at the University of Maryland is the Healthy Steps model. So bringing in an integrated developmental specialist that can really help parents during those, in one of our sites, actually, those 1,000 days where they're actually meeting with parents during the pregnancy period. And as you know, this visual just really helps us understand the importance of this sensitive period of development and the opportunities that are within it. As children go out past kind of age 8, and these mental health and developmental concerns haven't been addressed, more and more intervention and more effort are needed to help with adaptations and even recovery if possible. So these well-timed interventions really match up with the corresponding period of development. So you all see patients for a long time. I know my pediatrician for my kids, of course, I call it my pediatrician, even though he's my kid, he was my kid's doctor, right? But he's such an important resource to me. And over time, so you're monitoring and building relationship, you're monitoring development and you're building relationships over a long period of time. Your primary focus is prevention and refer out when, specialty care is needed. That family-centered approach is really an approach that can help parents talk about sensitive issues that are often surrounding concerns about development, concerns about adverse childhood experiences, concerns about things that are happening in the family that families could benefit from resources. So you really have an advantage. I sit in outpatient mental health therapy, and though when we can get parents to come and we can engage, they have kind of that, they can have a very deep connection with us. But that transition from that connection with you to a new specialist, or new, and particularly area where there's stigma around, can be quite a leap. So the more we can build those bridges together and help families and help you all, and we will have one of the modules around traumatic stress later with some of the resources that help discuss and identify adverse childhood experiences and traumatic experiences, I think are really an important opportunity. So I'm going to skip that one. So what I wanted to say here was that your relationship with the parent really is kind of the best predictor of being able to identify these mental health concerns early. Because when parents have that comfort level with you, they're able to talk about these concerns and these differences. And pediatricians are really the best people to draw those concerns out. And so looking for those nuggets that parents are dropping along the way and being able to engage them in a conversation. That said, I'm not naive about the difficult barriers around these sensitive topics, including, and probably most importantly, are the time limitations. We also know from other studies that primary care physicians and pediatricians say that this isn't, often part of their training and competencies. And so we're grateful that you're here today to build those skills and that knowledge base. Parents rarely bring it up, so using techniques like screeners and questions are really important strategies. And using open-ended questions rather than a closed-ended question from a provider, which kind of says, okay, the conversation's over. Because again, this is a conversation that usually has to unfold step by step rather than a yes or no kind of scenario. Okay. So, developmental surveillance and monitoring is your expertise. So parents and teachers and health professionals are really doing this all the time in real time. It's an ongoing process. And there's, tools like the Learn the Signs and Act Early Milestones checklist that can help with those conversations and help with giving people essential information so that they can be successful in their surveillance and not be too influenced by misinformation or wives' tales or myths or things like that. Developmental screening is a formal process and recommended by the AAP at 9 months, 18 months, 24 months, and 30 months development, and later for kids, but we're just talking about this early year now. And it's done by health professionals, pediatricians, nurses. It also can be done by teachers and other developmental specialists. And there are valid tools that can be used to support this process. Both look at developmental milestones, and both are important in tracking signs of development and identifying concerns. I think one of the best opportunities is that it's a place to first, particularly when you're doing screening, is to really lean into with the parent where development is unfolding in ways that the parents feel proud about, they can celebrate, they can recognize the strengths of their child. When there are concerns, that's when it's really important to have these more sensitive discussions and that really allow parents to talk about their concerns and maybe talk about some of the contextual things that might be relevant and might be playing into any developmental concerns that are identified on the screening tool. And then, working together to monitor and have an open conversation and, of course, refer kids to services as needed. The surveillance approach really kind of opens up that lens and opens up that kind of field of opportunity to regularly talk about and ask parents what concerns they might have. using the observation skills and observing parent-child interactions from the moment they're being picked up in the waiting area all through the the visit. Also, recording findings is really important so that together parents and providers can track developmental progress and maintaining that developmental history. So what's changed since we last met, and asking any about specific skills in developmental domains. I think the sensitive area often comes with identifying any protect risks and factors that parents might be concerned about, and keeping kind of an open communication about that, and also having trusted collaborators to refer families to. So I think we already said that one. Okay. So we know that screening is effective, and we know that mental illness and developmental delays may lead to multiple negative outcomes throughout child development and into adulthood. So it meets the criteria for the U.S. Preventative Services Task Force, which is that mental health conditions and developmental delays are common, and they have significant associated with significant morbidity or health problems, and we have effective screening and treatment. So when we have all those three things, really making the case for using tools is really important. So, the primary care provider team have lots of expertise in both surveillance and screening. And we know that, time is a concern around screening tools, but when best practice really shows that using the tool really helps the parent reflect and think through the child's development, and it sets a stage for effective conversation and guidance between being able to provide guidance to the parents. So there's lots of evidence and research that shows that these tools are highly effective. This study on over 3,000 children showed that about a quarter scored above the risk cutoff. So that kind of maps to our earlier prevalence talk as well. Just looking at the time. So so if about 1 in 8 children with identified mental health problems, so that's fewer than 50% of those clinically significant behavioral health problems. So we know that that we have a long way to go, despite the issues. And for many of us that have been around a long time, so often we think, oh, clinically we can just identify that. Well, that is true. You have good clinical skills. But in a fast-paced practice, and given that sometimes parents aren't prompted or don't feel comfortable to bring things up, we might be missing we might be missing the ability or the opportunity to identify behavior and emotional problems. So judgment alone is really not sufficient. And then biases and communication challenges can get in the way of us identifying children that need those supports. So we have good developmental screeners, ages and stages, the PEDS, the survey for young well-being for the young child, And we have good behavioral emotional screeners. In our practices here, we use the emotional screeners that are part of the SWIC, the Survey of Wellbeing for Young Children. I was wondering if folks would put in the chat what tools they like to use in their practice.
Somebody said they use the Survey of Wellbeing in Young Children, the PEDS, the Survey of Wellbeing in Young Children again. I think someone also mentioned the Ages and Stages tool as well.
That's great. So for some of these, like the Ages and Stages is a good example. It has the developmental domains plus a specialized tool for social emotional. The Survey of Wellbeing in Young Children has the developmental milestones plus a parent concern plus the pediatric and baby symptom checklists. So some of the tools are comprehensive in that they have both developmental milestone capacity and then additional questions around social emotional development and mental health concerns. And so that's really the recommendation. Starting in infancy, not waiting until children are 3 and older. So what tools do you have? The tool that you always have, which is anticipatory guidance and reflective developmental guidance. So parents turn to the primary care providers to kind of learn about, is my kid on track and what should I be preparing for next? So the anticipatory guidance. But we also, so that's very timely, it's very appropriate, it's very relevant. And when we add in the kind of the idea of reflective developmental guidance, that means we're not just going through using the tools to say what to expect next, but we're really incorporating the concerns and the conversation and the day-to-day things that parents are focused on. And so we call that reflective developmental guidance. And that at the heart of that, we kind of understand that parents have universal worries. And the basic worries are, is my baby all right? And am I a good enough parent? And at each phase of your child's development, what you're concerned about for your baby, is your baby all right? Are they sleeping okay? Are they eating okay? Or as they get older, are they making friends? Are they learning okay? Et cetera, et cetera. And am I a good enough parent? Am I reading their cues? Am I giving them, developmental stimulation that's helping them learn to make friends, et cetera, et cetera. So at each stage, those questions are different, but they're always kind of there at the core. And it really is throughout. I'm fortunate enough to have 3 kids, and they're all adults, and these are questions that still go through my head. So at every phase of life, parents are always thinking about these things. Are my kids okay? And am I an okay parent? So primary care providers, included the behavioral integrated care providers, can be reflective with parents about those concerns and putting parents' urgent concerns right at the center as a way to build that relationship and connection. And also taking a step back to reflect. So what has it been like for you to be this baby's parent? Is there anything you would like to think about together today? So those open-ended questions really help parents maybe say, well, I was thinking about this, or I didn't know if I should bring this up. These kinds of reflective questions really give that opportunity. And then before the time is up, saying, are we getting to what is most important, what's most on your mind today, or what's most important to talk about? So trying to prevent that back, as the door is closing question, trying to build in an anticipatory way that the parent might not think about all the things that they wanted to say. They might have had a list in their mind before they walked in, and you're halfway through the appointment and they haven't had a chance to rethink and ask those questions. So give them that opportunity. So in conclusion, we know that early intervention works. So early detection and prevention is really critical to improving outcomes, not just at these developmental stages, but really throughout the course of a child's development. And we know that supporting early child development, including social emotional needs, produces substantial educational, social, and financial benefits. So even though these can be sensitive topics for parents and providers to talk about, everyone wants kind of the same outcome, right? Everyone wants their kids to be healthy. Everyone wants them to be happy and have friends and be productive, in school and later in careers. So really kind of centering the conversations on those best intentions, that we all have the best intentions for kids. So take-home points are the foundation of health and human capacity is really about social, emotional, and relational health. We humans have a very long period of growth and programming the brain for successful adaptation to environment and culture. And so that is really done through relationships with parents and this network of all kinds of other people, extended family, neighbors, primary care providers, teachers, child care providers. There really is a whole network of people helping with that adaptation. And there's really exceptional capacity to learn. And children are really built to explore and to learn and to be curious. And if we can tap into these critical windows of sensitive periods of development and support relational, social, and emotional development, we can really meet our goals of helping to help kids be healthy. We have resources as well in the slide deck that will be shared, including the Learn the Signs, Act Early, Bright Futures, and I have to say I didn't check to see if the second one is still there. There, we will be providing a module on the updated CDC milestones. Dr. Gerard is going to be doing that. So we do have those resources in the upcoming webinar.
Great. Thank you so much for that wonderful presentation. We will open it up for any questions that you have. So please feel to place any questions in the chat or use that Q&A function. We had a couple as you were going, so I'll start with those. So when you were first talking about kind of like the course of mental health in younger children and some of the symptoms that they exhibit, someone asked if these behaviors might correlate with sexual or physical abuse.
Certainly they can, particularly those either some of the disruptive disorders. Oftentimes we'll have families referred with those concerns. And when we do a trauma screen, meaning we ask in behavioral health outpatient, we ask about, did any of these things happen to your child, including things that would be considered child physical abuse or sexual abuse. Because we can't diagnose ADHD if we then know that there is a primary trauma So we have to then do an assessment for trauma symptoms. And we know that children at this age group are more sensitive to traumatic events and more prone to having traumatic stress symptoms. So we treat that first, and then we see if there's other developmental, neurodevelopmental concerns like ADHD.
Yeah, and somebody
Also, anxiety is the other one. So that was a big one. About 10 to 20% of kids present that way. So, so there's the kids that are kind of externalizing trauma symptoms, and there's the kids that are more avoiding, withdrawn. So we have to look at that too.
someone just kind of commented as well, saying when you spoke about lashing out, sometimes parents don't know right away if there has been any abuse.
That is correct. Yes. Yeah.
Um,
And yeah, I'm sad to say that sometimes, and that's very hard for parents where, you know, their child has been maybe in a family member's care or a neighbor's care who they trusted, and, you know, that trust was violated. So those are hard things for parents to deal with. And so we want to support them with their feelings around that too.
Absolutely. Someone else commented when we looked at the first 100 BHIPP calls for children under 5, 30% of the time we had concerns for trauma for that pediatrician, and same for developmental concerns as well.
Yeah.
Another question for you is, our office uses ages and stages a lot, but we let the parents fill it in. Are you suggesting that a provider administer the questionnaire? Is that correct?
No, that is the correct way to use ages and stages. Yep. So the provider's role would really be to reflect on the scores and pull out any other concerns that a parent might have, and then talk with them about next steps if the child has is kind of in the either in the gray, which is usually a monitoring process, and if there's, you know, above the cutoff, then referral. And I think the research shows that parents are pretty good detectors of things that are outliers in development.
And another comment that says the American Academy of Pediatrics likes to say that mental health is health.
I love that.
About that.
Perfect.
Okay,
Yeah, that I guess I love that comment so much, because I was thinking that that's how we'll know that we've progressed, is that we really it is all integrated. So you guys are on the right track, you know. But we know that pediatric practices need more support to be able to provide those behavioral health supports.
Yeah, someone had also mentioned that the Denver is no longer allowed by Maryland Medicaid, so most of
Okay.
their providers use the ASQ, some the PEDS, and some other 6 or 7 screeners are available as well.
Thank you for telling us that. We'll take that one out. Thanks. I do think the survey of well-being for young children is kind of on the rise too, and that's a public domain tool. It's not hard to get built into your electronic medical records. So. And it really has all the components, the developmental milestones, the behavioral and family needs as well.
Okay, if you have any other questions, please feel free to put them in the chat or the Q&A function. While we wait to see if we have any other questions, just a reminder that the recording for today's session, the slides, and a list of related resources are going to be available on our website next week in the BHIPP training library. We will send CME and CU certificates to participants by May 7th. We will put the survey link for the evaluation into the chat, and we'll also send it out via email as well, so you all will have that. A couple of comments. Somebody said, I'm from Medicaid, Healthy Kids, so feel free to contact me for questions. We audit providers for use of objective screening tools. Mary Jo Harris. Thank you, Mary.
Oh, that's wonderful.
Okay, any other questions?
Well, I really appreciate, oh, that's great. I really appreciate everyone being here today and allowing me this moment for kind of a foundational talk to set the stage for future modules, including ones on traumatic stress, more details on the updated guidance around developmental milestones and screening. Um, and there'll be a few other wonderful opportunities to for Dr. Antonia Gerard to present and Dr. Sarah Edwards.
The next one that we will be hosting is going to be on June 12th. And Dr. Antonia Gerard will be presenting on that, and it's going to be surveillance and screening for young children in pediatric primary care. So stay tuned for that registration link to be posted out. And thank you all again for participating in today's session, and thank you, Kay, for a wonderful presentation. Please remember to take that survey as you exit. This is required if you'd like CME or CU certificates. And stay tuned for our other future BHIPP trainings by following us on social media or subscribing to our newsletter. And thank you so much again, everyone, and I hope you all have a great rest of your day.
Thank you, Lily. Thank you, everyone. Thanks for
Thank
being
you.
here.
Lots of
Thank you,
thank yous
Beth.
in the
Thanks,
chat.
Grace.
Okay. I can stay on for a couple more minutes to make sure everybody gets that survey link.
So if we take the three of us out, there was 55 people, you think?
Mhm. Oh,
Someone still needs a link.
I think so. At one point, they're all dropping off now, but it looked like there was around that amount. But we'll get the full attendance.
Oh, okay. Thank you,
Mhm.
guys.
Mhm.
Wonderful. Thanks for doing this. Thanks for getting this series going.
I'm really excited. I think it is a very much needed topic.
Good.
So
That's
very
awesome.
excited.
And maybe we can just, use the data to, because I think we have 10 modules. So I don't know if all of them will be wanted or needed, but we could use the data to say, hey, these are the ones that people asked for. So be responsive to what people want.
Absolutely. Yeah, but I know we're excited for Antonia's talk in
Yeah.
June. Let's see.
The other thing is, the modules are kind of built for to include the integrated care folks. So hopefully we can advertise we want those
Yeah,
people to come.
absolutely. Okay, let me see here. I think everybody.
Thank you guys. Do you need me for anything or?
No, I don't think so. Thank you so
All
much.
right. Thanks again. Thanks for the opportunity.
Yeah,
Thank
thank you. Okay, just want to make sure everybody's getting the survey.
Okay. Are you good? I'm
Yeah, absolutely.
great. Thanks, Lily.
See ya.